This is Anne. She just turned 40 and was diagnosed with MS 8 years ago. It took a while to find an MS drug, a DMT that worked well, but ever since her last switch 4 years ago, she hasn't had any relapses anymore. Every year she goes to see a neurologist, Dr. Bob. By now, she can already predict how that consultation will go. He will look at her MRI scan, perform some simple tests, and without fail, he will say something silly like, "Everything is hunky-dory, my dear." A few years ago, Anne couldn't wait to share this good news with her family and friends. But lately, she's finding it harder and harder to share Dr. Bob's enthusiasm. She used to love running, but nowadays, halfway a run, her foot starts dragging. Last week, she even almost fell in the mud. Her work has also been feeling more and more challenging. Even Jim Driftwood, of all people, seems to achieve more these days. And what's really getting to her is how utterly exhausted she feels by the end of each day. She used to be the family Scrabble champion, but lately she can barely come up with anything beyond the words cat or dog. She stopped mentioning these things to her partner and friends because what's the point? Without fail, their response is always something like, "Don't worry, Anne, that's just part of getting older. We all feel that way." I'm quite sure many of you recognize Anne's struggle. Let's talk about what's going on. This scientific paper explains it to us. The authors write that we have been wrong to think that a lack of active information or stable clinical test means that MS is stable. The paper is telling us that the MS community has been focusing too much on relapses and new spots on MRI, while all this time there has been another form of progression. Subtle, but significant. And that can go unnoticed for years. They're talking about something called SAW, Smoldering Associated Worsening. SAW explains exactly what's happening with Anne, and possibly with you, or someone you know. In this video, I'll explain in detail what Smoldering MS is. You will see how research and pharmaceutical companies are finally taking this seriously. But more importantly, I'll show you what this means for your MS treatment today. So, why did MS care get so focused on relapses and MRI spots in the first place? Until very recently, almost everyone, and this includes pharmaceutical companies, MS societies, healthcare providers, and yes, probably your own neurologist too, everyone was convinced that disability in MS was mainly caused by inflammatory disease activity, by clinical relapses and new spots on MRI. But why? Didn't they listen to actual MS patients? Well, if you thought the situation is bad now, imagine how it was 2 centuries ago. That's when her story starts. Because 200 years ago, doctors quite literally started poking around in the brains of deceased MS patients. These MS brains, they had several lesions that they could not only see but also feel. And that's actually where the name comes from, multiple sclerosis. It literally means several hardened spots. And logically, they assumed that those striking features were the main cause of the symptoms that MS patients were having. In the 1980s, MRI scanners started appearing in hospitals. And with these machines, doctors could see exactly those lesions in the brains of living MS patients. And when patients were having an attack, new spots would often be visible, further strengthening the view that these events were the main drivers of MS. Just a few years later, the very first MS medication was being developed. And that's where a story gets even more interesting. First, you'll need to understand something about orphan drugs. And no, co-pilot, these aren't medications for orphan children. An orphan drug is a medication developed specifically for a rare disease. Pharma companies get all kinds of benefits when they develop them. They get tax breaks, they can do smaller clinical trials, the approval process is much faster, and they get exclusive rights to sell the drug for at least 7 years, even without a patent. And don't get me wrong, those are good things, because without those benefits, they wouldn't develop any medications for rare diseases. Big Pharma would only focus on common diseases where they can optimize their profits. And that doesn't mean that these companies are nefarious, but they are companies with boards and shareholders, meaning that to survive, they have to focus on making money. In 1988, Chiron Corporation, now part of Novartis, and Berlex Laboratories, now part of Bayer, they were working together on the very first MS drug, interferon beta, branded as beta seron. But there was an inconvenient detail. The FDA considers a disease rare if it affects fewer than 200,000 US citizens. And in 1988, there were 300,000 people with MS in the US. With today's diagnostic criteria and better technology, that number would probably be more than 3 times as high. In any case, the number was too high to qualify for an orphan drug status. To sidestep this inconvenient financial hurdle, the companies devised a clever workaround. They would only focus on people with frequent relapses. Only patients who had at least 2 documented relapses in the past 2 years could participate in their studies. And just like that, they stayed under that magic number of 200,000. Focusing on active MS had more advantages. First, animal models for MS, usually mice with EAE, they model the inflammatory aspects of the disease, not the progressive deterioration. And second, relapses and new MRI lesions, they are easy and quick to measure. And third, because they are so easy and quick to measure, the clinical trials, they can be short. The studies for beta seron, they only lasted for 2 years. Nowadays, almost everyone knows the terms RRMS, SPMS, and PPMS, but this official classification didn't come out until 1996. That's 8 years after those beta seron studies. And it's important to understand that this classification is based on how the disease looks clinically. Biologically, there is still no basis for this subdivision. If you show the pathologist microscopic sections of the brains of someone with RMS, SPMS, and PPMS, they wouldn't be able to tell you which one is which. These days, MS is far too common to qualify for an orphan drug status. But that clever workaround from 1980 has lasting consequences. It set a precedent for all MS drug development that followed, shifting the entire focus to RMS and acute inflammation. Even today, the FDA in America and the EMA in Europe, they firmly hold on to the categories RMS, SPMS, and PPMS, and they still treat relapses and MRI lesions as the gold standard for approving MS medications. But stopping these inflammations isn't the complete answer. This was spelled out in this article in the prestigious New England Journal of Medicine, published almost a quarter century ago. Yet somehow this knowledge got sidelined, and most scientific research and drug development stayed focused on active inflammation. Not so long ago, things finally started to change. In 2020, this pivotal paper was published. This study finally gave a number to the importance of what they call PIRA, progression independent of relapse activity. Let's have a look at what they did, because it's really quite simple and insightful. The question these researchers wanted to answer was simple. What proportion of disability in MS is caused by relapses, and what portion by something else? Or in their terms, how much disability comes from RAW, relapse associated worsening, and how much from PIRA, progression independent of relapse activity? To answer this question, they needed data from a large group of MS patients with consistent measurements taken regularly over an extended period of time. The two trials that tested ocrelizumab, or Ocrevus, about a decade ago, they provided exactly what they needed: a large data set of over 2,000 people with MS, measuring them thoroughly every 12 weeks for nearly 2 years. And while Ocrevus was approved in 2017, after proving to be highly effective against active inflammation, the trial data had been carefully preserved. The first step was to define how to measure disability worsening. The standard measure in MS is the EDSS, the Extended Disability Status Scale, which runs from 0, no problems, to 10, death due to MS. But EDSS has several problems. For example, it's quite crude and it's heavily focused on walking ability. That's why the researchers also included two other tests that were measured in the OPERA trials: the T25FW, which is a timed 25-foot walk, where you walk 25 feet as quickly as possible, no running allowed, and the 9HPT, the 9-hole peg test, where you have to place 9 small plastic bags into holes as quickly as possible. And they combine these measures to determine if someone had CDA, confirmed disability accumulation. All right. Let's say we have two study participants, A and B. Let's call them Anton and Bonnie. And during the study, they both have a relapse. Unfortunately, Anton didn't completely recover from the relapse, but Bonnie did. However, later measurements show that Bonnie gradually did get worse. The worsening of Anton is related to the relapse, hence the name RAW, Relapse Associated Worsening. The researchers defined that worsening that occurs 90 days or more after a relapse is independent of that relapse. Therefore, the worsening of Bonnie is named PIRA, progression independent of relapse activity. A combination of both, as you can see here with Claudia, of course, is also possible. With these rules, the researchers could analyze RAW and PIRA events for all the participants in the OPERA trials. And not everyone in those trials was on ocrelizumab. Half was a control group. They got interferon beta. Remember that first ever developed MS drug? I wonder who would win. Well, as expected, there was a dramatic difference in the number of relapses people had on those two different drugs. However, surprisingly, they found very little difference in how many people actually did get worse. Why? Only about 1/5 of disability worsening was caused by relapses, by RAW. The vast majority, 4/5, was caused by PIRA. That paper was published 4 years ago. Today, most experts finally agree. Relapses in MRI activity only play a small part in the disability accumulation in MS, even early on in the disease. This insidious part of MS worsening is what they call smoldering MS, and that includes more than PIRA alone. The best way to explain that is by looking at figure 1 of that consensus paper. Here you see an example of how disability can accumulate over time in someone with MS. And of course, this is just an example. As we all know, MS progresses differently for everyone. But this example gives us good insight and corresponds well with Anne's story. I've recreated this figure so that we can go through it step by step. Let's start with the axis. Time runs along the horizontal axis, while worsening increases on the vertical axis. And MS actually starts before anyone notices it. This is called the preclinical phase. Then, often during a relapse, the disease becomes noticeable. This marks the clinical onset of MS. Getting the actual diagnosis may take longer as all diagnostic criteria need to be met. Looking at the entire course of MS, the pattern of worsening might look something like this. Here in green you can see the worsening from relapses. And friends, they did have a point. Some worsening comes indeed from normal aging. But that's only this tiny blue fraction. What's unaccounted for is this large orange section, which is referred to as SAW, Smoldering Associated Worsening. Only this light orange part of SAW is called PIRA. The simple reason for that is the definition that was used for PIRA. Remember, it was only taking into account the EDSS and this timed 25-foot walk and the 9-0 peg test. But look at this darker orange section. This represents all the worsening that those tests simply can't measure. We can measure some of it with tests like neuropsychological evaluations, neurological stress tests, maybe certain biomarkers, but much of the worsening remains hidden from our current tests. This is crucial for us to understand because these hidden symptoms like fatigue, cognitive problems, pain, depression, etc., might be invisible to others, but they have a huge impact on our daily lives. The fact that they can't be measured doesn't mean that they don't exist. The good news is that the focus of MS research and even drug development is slowly shifting. With more than 24 MS medications already on the market, pharmaceutical companies needed to find new ways to make more money. I mean, they needed to find ways to help people with MS. A few years ago, they started investing billions in BTK inhibitors, medications that might actually impact smoldering MS. And suddenly, the same companies that had been ignoring this aspect of MS for years started passionately highlighting the importance of smoldering MS. Even if these drugs don't do as well as we hope, pharmaceutical companies, they cannot go back to ignore smoldering MS anymore. What's that one Americans say again? Something about a cat in a bag. Ah, yes, they have let the cat out of the bag. Why would there be a cat in the bag? Is that correct? But while new treatments are currently being developed, we can't just wait and ignore these invisible symptoms. Luckily, there's already a lot that can be done right now to deal with these symptoms effectively. In fact, there's a whole network of specialists who can help manage these different aspects of MS. Fatigue can be managed with the help from a rehabilitation doctor or occupational therapist. Cognitive issues can be worked on with a neuropsychologist, etc. There's so many. I created this figure, but I guess I still forgot many specialties. There are really a lot of them. And what's more, treating one symptom can often help improve other seemingly unrelated symptoms. Let me explain. We all know that things get harder when we're tired, or how depression affects both our energy and our ability to concentrate. But this connection between symptoms goes even much deeper. For example, if you're sensitive to bright light and you're reading something complex online, switching to dark mode might actually help your brain process the information better. This is because your brain isn't working as hard to deal with the bright light, so it has more energy available to understand what you're reading. And this translates to all other symptoms. So don't let good MRI results or stable tests dismiss what you are experiencing. Remember, not all symptoms might show up on standard tests, but they are real, they matter, and there are ways to manage them effectively. The sooner you recognize them, the sooner you can take control and learn how to handle these challenges. If you notice any changes, bring them up with your neurologist at your next consultation. And if that's too far away, reach out to your MS care team now. They can help coordinate which specialist would be most beneficial for your situation. Thanks for watching. I hope you learned a lot.